Hello, everybody. Dr. Richardson here. Welcome to the first lecture in Foundations 2. As you may have seen on the announcement on Canvas, we are now in the second class of the Foundation sequence, and we are definitely shifting gears. If you want to think about it in terms of patient treatment settings, we are moving now from more of the outpatient orthopedic setting to more of an inpatient setting uh, with the different types of material we'll cover in this course. And for some of you, this will be uh, foreign territory, new for you. You won't have the comfort level that perhaps you had last term when we were in the outpatient ortho world. And there are some of you who I know have spent quite a bit of time working in these types of settings. So when I say inpatient setting, I would be referring to the acute care hospital. Uh, Physical therapy plays a very significant role in this setting. It might also be a subacute setting or a skilled nursing facility type setting, which are sort of offshoots from the acute care setting. And then it also may extend to uh, an inpatient rehab type setting. And so there are differences among those, which we will discuss at different times during this term. In essence, the acute care hospital setting is very much a triage mentality for the physical therapist. Our goal in that acute care hospital setting is mainly to assess a patient's mobility, their potential, and make recommendations for equipment that will be needed and also for discharge planning. Are they safe to go back home? Do they need to have additional care before they're safe to go back home and so forth? Um, Often, when those patients, for numerous reasons, are unable to attend home, it could be for medical reasons, such as they need extra time for intravenous antibiotics or recovery time from a surgery. The acute care hospital may need to have them discharged, and so that's when some of these patients may go to a skilled nursing facility, a subacute floor or a subacute unit, where they will receive some additional skilled care before going home. For other patients who have find themselves in maybe a longer term type scenario after having, for example, a stroke or a traumatic brain injury or other medical issues, may send that patient to an inpatient rehabilitation hospital or unit where they will be treated a little bit longer term before they go to their next destination. So all of these types of settings in this inpatient world have some unique considerations for the physical therapist. A lot of times, as we generalize, we would say many of these patients are sicker. They have more medical history in many cases. Often they are older, and the general level of mobility in many cases is lower. And so in this first lecture today, we're going to talk about positioning and draping, the importance of protecting patients when they are unable to move themselves in bed or in a wheelchair. Their skin is at risk, their joints are at risk. And as we know, movement is so important on many, many levels. And so for these patients who are unable to move themselves at all or as much as they typically would, often the physical therapist intervention is to protect their skin and joints and so forth. So that's kind of a general intro to Foundations 2, some of the different types of patients and settings that we will be discussing. So our objectives for this lecture are to talk about proper positioning, uh, why positioning is a consideration at all, and then procedures for uh, changing patient positions and draping them and so forth. Relieving pressure is very important to protect the skin. So we'll talk about methods for pressure relief as well as what we call bridging the gap. We'll talk about footboards and proper positioning techniques. So when we think about patient positioning, we want comfort, of course. We want the patient to be able to access their environment. And that may mean many different things. That may mean their ability to see what's happening in the room, or also their ability to move within their environment. We want to prevent deformities. We talked last term about contractures, a fixed limitation in a joint. Also, pressure sores involve the different layers of skin, and so we'll talk a little bit about that. Providing access to the environment, and then also there are certain treatment procedures. We may be working on some strengthening or some stretching, and we want to make sure that the patient is maintaining their privacy and dignity while they're doing that. So as we all probably have experienced with family members, if you think about an elderly person in your family or with whom you've been in contact, you may have seen and been able to appreciate the changes that occur with the aging process. There are, and in essence, the skin is more fragile as a patient grows older. There's decreased thickness, decreased blood supply. The skin is less extensible and pliable with age, and also with mechanical depression. And mechanical depression can mean the greater trochanter resting against the side of the wheelchair. It could mean the calcaneus resting on the bed as a patient lies in the supine position for an extended period of time. But any kind of pressure on the skin with aging, the skin is less able to recover from that. And then also neurosensory perception. Often, a lot of these changes take place at the cellular level, and often patients are less able to sense pressure and sense pain, and they're unaware that maybe damage is being done to skin, and therefore those position changes are necessary. So some of the general procedures we want to talk about, of course, as physical therapists, we want to protect ourselves, therefore body mechanics. We talked about that last term. Carries over into everything we do as PTs. We need to make sure that we are looking out for ourselves and using proper body mechanics. In general, because of the fragility of skin, we want to, whenever possible, not have the skin be dragged across surfaces. And so, for example, a patient's lying supine in bed and they want to move from one edge of the bed to the other, or we want to help them move. Instead of dragging them to the side of the bed, we want to do everything we can to have them perform what we call a bridging technique, where they're lying supine, they bend their hips and knees so their feet are flat on the bed, they push down with their feet, raising their hips up, and then move their hips to the side, lower their hips back down again, and that way they have avoided dragging the skin. We want to be very aware of bony prominences. There will be a slide later in this presentation that shows all the different positions and which bony surfaces are at risk. So we definitely want to be aware of, in different positions, the bony prominences that will be exerting pressure on the skin and therefore potentially putting the skin at risk. And then, of course, we want to maintain patient modesty and dignity. Very often in these inpatient settings, patients are wearing nothing but a gown, and so at times there will be many different strategies that therapists will use, such as wearing another gown. Opposite, in the picture you see here, the gown's opening in the back. Sometimes when we're going to go for a walk, we can put another gown on, opening in the front. So now we have two gowns and everything is covered. But we'll talk more about that. So in general, the idea for relieving pressure is we're trying to disperse pressure. So when you think about an elbow laying on the bed, if the point of the olecranon is pushing into the mattress, that's going to put a lot of pressure on that specific skin right over the olecranon process. And so if we're able to extend the elbow and have the weight of the entire arm lying there, we have dispersed that pressure. And of course, we want patients to be comfortable and have them be able to access their environment, and have caregivers be able to access the patient to provide various treatments. So we want to, as I said, avoid direct contact on bony prominences. Even wrinkles in the bed sheets can be harmful to patients with very fragile skin. Often changing positions frequently is very important. There are some situations with patients where they are on what we would call a turning schedule or a positioning schedule, and various members of the rehabilitation team, might be nursing, might be the therapies, will be responsible for every hour, every 2 hours, whatever the patient needs, changing position from left side lying to supine to right side lying and so forth to minimize the amount of prolonged pressure on a bony prominence. And sometimes some hospital beds have a trapeze where a patient can reach up with their arms and use their arm strength in that way with a trapeze to move themselves in the bed. Often there are draw sheets in hospital beds that are an additional sheet that is used just for helping patients to move, and it'll often be about the level of the scapula, and so people on both sides of the bed are able to use that sheet to lift the patient and slide them up in bed, for example, or from side to side. Um, and we want to have a patient, we want to avoid having a patient having an extremity hanging off the edge of the bed. That's obviously going to be problematic. So here's the slide that you can appreciate looking at every potential area that could be at risk when a patient is sitting or supine or side lying. And so we won't go through each one of those, but that will be critical for you to be aware of in each position, supine, side lying, prone, or sitting, what bony prominences are going to be putting the patient at risk for skin trauma. So there are some different dispersing mediums. There are different kinds of beds and wheelchair cushions that basically do exactly that, disperse the pressure from these bony prominences. Patients who are at significant risk due to paralysis or extreme deconditioning will often be utilizing these beds or these surfaces to hopefully avoid trouble with their skin. Um, so there are many different ways to kind of bridge the gap and disperse the pressure from bony prominences. Often pillows are used in different areas, as is illustrated on this slide, to elevate the legs so the heels, the calcaneus is not in constant contact with the bed, between the ankles so that the medial and lateral malleoli are not causing pressure, and so forth, all these different areas. And there are other types of positioning equipment that can be used as well. And here's some examples. We see on the top left a cushion for the elbow for that olecranon process. We see on the top right one method to alleviate the pressure on the calcaneus. Often that is a very common area for bed sores. The bottom right, we see another way to eliminate pressure on the calcaneus, where the entire lower leg and foot are raised, and you can see that the actual heel is kind of hanging in space there, but the rest of the leg is, or the lower leg is protected. Walking boots can also disperse pressure, and then we see there are a series of donuts that can be inflated, and these can be used perhaps on the sacrum in different body parts. So the inner part of that inflatable donut is now kind of suspended in space and doesn't have the same amount of pressure on it. So these are some thought processes for you to go through to consider different positions, what types of positions would be putting the patient at risk at different body parts. Sounds like an exam or a quiz question to me. Also, you can consider different patient populations and which types of populations would be at risk for various reasons, and consider that. So we talked about bridging the gap, and it is exactly that, just making the pressure not be on that bony prominence. And the final area are just footboards. We're trying to, in this case, prevent the patient from sliding downward in the bed and prevent plantar flexion contracture. So these are all important ways that we can eliminate pressure on skin.